Well, hi everybody and welcome. Sorry, I've been furiously closing extra open windows on my computer. Um, so we are back for the fall and hope everyone had a good August break. And for today, we've got a plan to talk about the AIDS 2022 conference. So if people were there or virtually or not, would love your additional thoughts. And hopefully we'll have some good topics for discussion. So if there aren't any announcements, and I'm not aware of any, I'm going to get started with the presentation, but please feel free to interrupt me at any point. This is not at all meant to be formal or so. And can someone tell me, should I switch my screen or is this the right one?
It's right.
Good.
Okay, thank you. Okay, great. And people actually talked. So AIDS 2022 was in Montreal, and although for me actually was in Baltimore because they also had a virtual platform option, which worked well. I don't know how long that's going to continue for conferences, but these are some of the disclaimers about what I'll present. This is a sampling of what I found interesting in the conference. It is a huge conference with lots of really interesting things in all different tracks going on. So just a sampling and not meant to be comprehensive. I'm going to start from the aspirational type of findings that were presented from the vaccines and cure, and then focus most of the time on the more practical prevention, pathogenesis, and treatment studies that were available. So from an HIV vaccines perspective, there was some data presented at the conference. So the question, as we often think about in our goals of ending the epidemic or, really getting a handle on the HIV epidemic, both in Baltimore and worldwide, a vaccine is critical. So what was presented at the meeting was an immunologic analysis of the Imbokodo trial. So this trial is a study that was done in HIV uninfected women in sub-Saharan Africa between the ages of 18 and 35 who are at high risk of HIV infection. And the primary objective of this study was to assess vaccine efficacy to prevent HIV. The study was based on an adenoviral Ad26 vector with a mosaic antigen insert, which with HIV, and then a boost after that initial ad vectored vaccine that had the clade C GP 140 to stimulate local clade C immunity. As you can see from the vaccine schedule, it had 4 different injections, which already presents a lot of problems, I think, for rollout of vaccines, as we've experienced with the COVID pandemic and how hard it is to get people to get multiple doses. But that said, if it were effective, still would be hugely beneficial. So unfortunately, the primary results of this trial have already been presented and published and did not show any protection. There was no difference in the incidence of HIV. But as with all of the vaccine trials that have been done to date on this scale, what follows is a subsequent immunologic analysis to see if there's anything we can learn from the vaccine results overall. So this gets into what we call an immune correlates analysis. So where people will measure multiple features of the immune response to HIV, either to the antigen itself or to circulating HIV, and see if any of them seem to correlate with higher levels of protection. So they assessed a number of these measures here, and they presented data on a couple of them. So the total immunoglobulin response to vaccine subtype C, so how well we got an IgG response to the thing we vaccinated you with, antibody-dependent cellular phagocytosis, so a non-neutralizing antibody function that may be important, and then the breadth of IgG3, a particular type of immunoglobulin, to the V1, V2 loop, and then to the overall envelope antigen. And what they saw with these 4 or 5 focus analysis is that it looked like IgG3 V1, V2 breadth may trend towards correlating with an actual protection from HIV. But I'll point out here in this graph down here, they analyzed it in a couple of different mathematical models, but the only thing you need to see from this graph down here is that the green bar indicates the prevalence of individuals within each range of IgG3 titers. And most of the people had very low IgG3 V1, V2 breadth. So in most cases, this vaccine did not elicit this signal, which may or may not be associated with protection. So even if this is associated with protection, this vaccine didn't really do a very good job of making it happen. And that leaves open the question of whether or not we can elicit that type of a response with other vaccines. So for exploratory markers, there was no relationship with protection. These are the sort of traditional things you would expect to see from a vaccine elicited response and would hope that they would be related to protection, and then that was not the case. So what does this study add, to where we are right now? An HIV vaccine remains very challenging. There have been now several studies that have looked at IgG3, this particular type of immunoglobulin response, and shown that it seems to be related to protective responses. This includes the RV144, as well as one other HVTN vaccine trial, and then this Imbokodo trial that they presented here. And then the V1, V2 loop, which is up here on this portion of the HIV antigen, which seems to be an important target in particular when IgG3 responses are elicited. So I think those are the sort of take-home points. Those two things seem to have emerged from a couple of different platforms and trials that they would be good targets. The other message is that those responses are elicited in a minority of participants. And so far, even if they are protective, we don't have good ways of getting there. So current vaccine trials, there's an ongoing, this was the HVTN 705 trial, 706, Mosaico is ongoing, looking at a similar adenoviral 26 vector with a slightly different boost. And then there's a couple of other trials, including some new exploration of mRNA platforms, but we still are not quite there. So I think the questions from the cumulative data from the HIV vaccine studies, there were a few others. A novel arenavirus platform was presented in animal model systems, but are there host factors that are determining whether or not you get the response, or is it the vaccine itself? And if it's a host factor, then that's a major problem, because that means that some people just can't elicit these responses. Hopefully it's related to the vaccine itself, and then we can find one that will skew towards protective profiles. And then the other question is, are these correlates, meaning they just are related to protection, they travel along with protective responses, or are they actually the reasons for protection? Because we could go down a rabbit hole of trying to get perfect IgG3, V1, V2 loop responses, but if that's not actually the protection, but it just goes along with protection, then we will not achieve our results. And then what remains, there were a couple of studies presented on broadly neutralizing antibodies in other formats. And we still have this question of whether broadly neutralizing antibodies alone will be enough, or will we also need to elicit good T cell responses. So that's a somewhat not super exciting update from HIV vaccines at the meeting. So if we can't prevent it, can we cure it? What were the new studies in the cure space at AIDS 2022? So the first one I'll mention briefly is an exceptional elite post-treatment control case. So this was a 59-year-old woman who at the time of diagnosis had symptomatic, what was described as acute HIV infection after sexual acquisition, although she was Phoebig stage 5 at the time of starting antiretroviral therapy. Her baseline viral load was 70,000, her CD4 count was greater than 800, and she was enrolled in this trial that was being done at the time called the Immune-Mediated Primary HIV Infection Randomized Controls Clinical Trial. So as part of this trial, she got sort of an immune picnic basket of treatments. She got cyclosporin A, and then during her initial period on antiretroviral therapy, then had an analytic treatment interruption. And during that time, she was treated with GM-CSF and interferon alpha. And then antiretroviral therapy was reinitiated with IL-2. And the overall goal of this was to sort of stimulate the optimal immune response while allowing exposure to HIV so that an appropriate T-cell based anti-HIV response would develop and potentially make her able to control her HIV. The results of this trial did not show that that happened in most patients, but as part of the trial, she went on an analytic treatment interruption and has continued on that treatment interruption for now more than 15 years without experiencing viral rebound, as is shown here. So what did the additional studies they do about her? So she did not have any of the classical factors that Joel would have immediately identified in her of a protective HLA allele or CCR5 deletion. She was homozygous for B44, so not a protective one. She has an NKG2C wild type allele. This is an NK cell marker that has been linked to some features of HIV immune responses, but never with strong enough for elite control. And over the time period of the study, she's had a progressive decline in her HIV reservoir, although she still was QVOA positive at 9 years. And the QVOA is the assay that was developed and pioneered by the Silicano lab here at Hopkins that really gives you a quantitative assessment of how much virus you can grow out of your cells, and is still the gold standard for determining whether a virus is still within the reservoir. And that was positive at 9 years. So at least at that time, she still had replication competent virus, but was controlling it with her own immune system. So what parts of her immune system are controlling it? They next did some testing where they looked at HIV viral replication. This is using total peripheral cells, they are the gray bar, the PBMCs, or only CD4 T cells from HIV negative healthy donors. And you see good, robust HIV replication. In this particular individual, when you culture her CD4 cells alone, so the red bar, you get pretty good HIV viral replication. So the CD4 cells can certainly support HIV infection if you do this in a culture dish. However, when you did the infection with her own other peripheral blood cells present, there was actually a marked reduction in the percent of HIV replication. So to figure out which cells were causing this sort of reduction in HIV replication, they looked specifically when you mix CD4 cells with CD8 cells, and they saw a decline in HIV replication. Then if you mixed her CD4 cells with her own NK cells, you also saw a decline, and together there was an even further decline. So with some more immune phenotyping, what they determined was that she had an enrichment of memory-like NK cells and an enrichment of CD8 positive gamma delta T cells that also expressed an NK cell marker NKG2C, which is also expressed sometimes on CD8 cells. So the bottom line from this is that atypical active immune control is allowing continued control of replication competent HIV in this particular individual. It is a model of a functional cure in the absence of any known favorable genetics, which is always, one of the problems with elite controllers is if you just got good genes, we can't really turn anybody else into that same phenotype. So that's always a limitation. And it's unknown whether the multiple immunologic interventions that she had early on contributed to the emergence of this control, or if it's something that would have happened either way. But she is yet another patient to add to the list of trying to understand how it is that some people are able to control HIV. Another patient who is added to that list is the City of Hope patient. This is the one that was profiled in a couple of mainstream media articles, and probably is the one that patients will bring up when they come into the office. A 66-year-old with HIV diagnosed in 1988 with a AIDS CD4 nadir less than 100, but an undetectable viral load since the 1990s. In 2018, was diagnosed with acute myelogenous leukemia and received an allogeneic hematopoietic stem cell transplant from a matched unrelated CCR5 delta 32 donor. So lacking the CCR5 co-receptor is depicted down here in the picture, which blocks HIV entry for R5 tropic viruses. So patient was treated with antiretroviral therapy with dolutegravir and FTC-TAF through 25 months post-transplant, and then had an analytic treatment interruption. So this is taken directly from the graphics from the presentation. And I will just mention briefly that only the Dusseldorf patient is not included in this chart. And there's some controversy within the field about whether that patient should be included as another functional cure. The reason that he's not in general is because there was only one report and no publication, and the duration of follow-up at the time was relatively short. But he apparently has gone public, at least with his first name in the mainstream media in Europe, and is another potential example of cure. But on this chart, we can compare the patients who have previously been reported to have a cure related to a stem cell transplantation, with the City of Hope patient being this newest example, and the work from Impact P1107 and Devi Prasad, the reporting a patient earlier this year at CROI. So the things that came out of this patient are, reduced intensity conditioning because of the age of the patient, the long duration of HIV infection, and the lack of significant graft versus host disease all did not seem to prevent this individual from developing what appears to be sustained HIV remission. So 100% donor chimerism, meaning all of the cells in the body were replaced by the stem cell transplant, at least the ones that we detect in the peripheral blood. Although the HIV serology remains positive, this has been variable between patients. So suggesting that there's a long-lived B cell somewhere that was still producing antibody to HIV. The same is actually true for their hepatitis B core antibodies. So this was a patient who had a history of being core antibody positive, which, leads to the question of whether or not you would interrupt treatment, because if the patient had hepatitis B infection, stopping a tenofovir-based regimen could be problematic. The reason that the study team opted to do this was that post-transplant, the patient was vaccinated for hepatitis B and developed a robust surface antibody titer. But the Hep B core antibody positivity here just suggestive, again, similar to the HIV, that there's a long-lived population of some immune cells in the bone marrow, but those are likely B cells. There are no HIV-specific T cell responses, although there are good CMV positive responses, and most of the virologic assays have been negative. And I have sustained now absence of viremia despite interruption of treatment. So where to go from these clinical data? Bone marrow transplants have been successful in several instances, but not all. And the denominator of this is always challenging, because there have been many more than just the reported cases, CCR5 delta 32 transplants, and not all of those have led to functional cure. And are there more ways to understand what is happening in post-treatment controllers and to figure out a more feasible pathway to a functional cure? I think there were a lot of questions from the community during these presentations about how maybe a functional cure is a better model, because most people are not going to undergo a bone marrow transplant. But I think we still don't have that many tools to get us to more functional cures. And just to sort of round out this part of the presentation on the curative studies, do we need to go back to the lab to refocus efforts at cure? I mean, the answer to that is surely yes. There was a really nice talk from Eli Boritz from the NIH, who has developed a method of doing sequencing to look at the RNA that's expressed specifically in cells that contain HIV DNA, and so specifically in latently infected cells. There's a couple of different approaches to this, and they all have cute names. This one's find-seq. There's other sort-seq and other ways of looking at this. But of the 18,000 genes that were expressed in these CD4 cells, there were only 44 of them that were different between those that harbored HIV DNA and those that did not. This included 4 negative regulators of HIV transcription, so things that would keep HIV silent, 4 positive regulators of HIV transcription that were downregulated, and then some other RNA processing regulators. So those themselves are a strong signal that this methodology worked, that these long-lived cells that have silent HIV have some active upregulation of things that are silencing HIV transcription, would be the suggestion from these studies. And the findings were that HIV reservoir cells are different. They also had some pro-survival signals, so anti-death receptor, anti-apoptotic pathways that would maintain the reservoir cells over time. And they appear to be better at silencing HIV transcription and managing post-transcriptional processing. So there were lots of other studies, but those were the few that I chose to highlight. And some impressions from the HIV cures that, I feel like every time there's an instance of someone who has a functional cure, this is really a signal of hope, but a delineation of the many remaining unknowns of how to get more patients to achieve this type of outcome. And then HIV vaccine and cure studies still struggle with similar challenges. What are the best endpoints? Should we be looking at immune correlates or time to rebound and rates of infection? How will vaccine trials move forward in an ethical manner when there's available highly effective PrEP that will reduce the incidence of HIV even further? How do we sort out what things are just related to an outcome versus actually causing an outcome before we try to make big efforts to target them? And then what features are individually determined and sort of not possible to change, and what features can we change with different stimulation regimens or vaccines? But they both have similar mandates. We need to find a way to stop HIV, and we're not at the global targets for ending the epidemic, and certainly urgently need more research in all of these areas. So I was going to move on to more practical studies on pathogenesis and treatment, but just will pause here if anyone has any comments or thoughts on other things that they found interesting at the meeting. Please feel free to chime in or put something in the chat. Okay. Oh, did I hear someone? Okay, I'm going to take that to be the acceptable Zoom interval and roll on through to some more prevention and pathogenesis pathogenesis and treatment studies. So HIV prevention, there was an abstract presented at the co-chair's choice session partly from the people who developed AIDS View. So if you don't know AIDS View, I find it to be a very nice resource for looking at a lot of different metrics of HIV in the US. You can look on a country level and a state level, county level. They have demographic data, education data, broken down by sex, gender, race, and ethnicity, lots of different things to explore when thinking about HIV in the United States. And what they're presenting on here was a new metric on their website called the PrEP to need ratio. So it's the number of people on PrEP and the number of new HIV diagnoses. And it's an equity metric that doesn't have any target. There's no, like, this is the right level that we should be achieving, but sort of useful for identifying where we need prevention strategies to be focused. And the data is limited by, being available prescription databases, but I think quite informative. And so what's graphed out here on the right is the PrEP to need ratio in different regions of the country, the Northeast, Midwest, West, and South, and then broken down by Black, white, or Hispanic. And what you can see is that it's clear that white people in the United States are accessing PrEP at much higher levels than Black and Hispanic people, even though the risk of HIV is disproportionately borne by those other communities. And I just put here, a couple of years ago, I had the opportunity to write a little piece with Joel Blankston and Ethel Weld about PrEP access and utilization in the United States. And we sort of identified the same issue, which is that on the left here of this pie chart is who is at risk for HIV infection, and on the right is who is prescribed PrEP. And you can see that this dark blue area is white, which has only a quarter of the risk, but really the dominant rate of prescription for PrEP in the United States. And then sort of exploring the data again, from a male-female ratio, because in the US, we have a hard time identifying women who would be at risk of HIV acquisition and candidates for PrEP, and women have a hard time identifying themselves, also showing a disparity in prescription. So I did look at the AIDS View today just for Baltimore City 2021 data. And actually, we're doing pretty well. For every one new HIV diagnosis, there are 4.69 HIV PrEP users, which is good overall and on the higher range of coverage. In males, it's, for every one HIV diagnosis, there are 6 people on PrEP. But in females, we're close to 1-to-1 in terms of definitely don't have, all of the potentially at-risk people on PrEP because of the one HIV diagnosis to 1.76 PrEP users. So some work to do in particular in that community. And in Baltimore, they don't have the PrEP data broken down by race ethnicity, but in Baltimore City, Black women are 21 times more likely than white women to have HIV. So clearly this would also be largely borne by Black women living in Baltimore City. So what other updates were there on pre-exposure prophylaxis? So there was an update on long-acting cabotegravir from HPTN 084. So this is the international randomized double-blind phase 3 trial of more than 3,000 sexually active 18 to 45-year-old cisgender women, comparing cabotegravir injection versus TDF FTC or Truvada. And so the primary analysis had already been reported, which showed that the HIV incidence per 100 person years was 0.2 for cabotegravir and 1.85 for FTC TDF. The updated data that was presented at this meeting included the unblinded phase through December of 2021, and it remains extremely effective with a HIV incidence of 0.18 per 100 person years for cabotegravir and 1.7 for FTC TDF. There was one additional infection that was recorded during the oral lead-in phase of cabotegravir, but they actually showed that there was no cabotegravir detected in the system of the individual who was infected. So they didn't take it during the oral lead-in, although they did get the first injection of cabotegravir because it was not detected on the 4th generation assay done at the time of initiating therapy. Retrospectively, a viral load done from that visit, after the diagnosis was established, did show an HIV viral load of 8,000 copies. So overall, continues to be extremely effective. I continue to feel a little bit hesitant about use of CAB, but I think there's I probably need to unpack my own assumptions about that. For me, largely the potential duration of the tail is what makes me a little bit concerned. But I think, we have not seen a lot of infections during the tail, or resistance from that problem. So, I mean, the data actually is very strong that this is highly effective, in particular in a population for whom adherence to Truvada was not really optimal, which is, cisgender women in sub-Saharan Africa, where uptake was poor. So I'll just pause there. If anybody, I think I saw Joyce, and who does a lot of work in PrEP and prevention space. I think, there was some sobering data about how we're not close to our targets for ending the epidemic, but this was the main thing from PrEP. There was also a little bit of data for PrEP in trans women, high rates of infection in trans women in the United States that was confirmed, but also what was confirmed was, and this is from HPTN 083, which is the cisgender men and transgender women, the study of cabotegravir versus TDF-FTC, and that also showed that there was no interaction with hormonal therapy and it was equally efficacious. So good news that CAB works well, even in very high risk populations and where there was thought to be maybe a potential for a drug-drug interaction. Thoughts on prevention?
Just to say that Kristen Kilcrease really led the charge to get this on formulary. So it is now on formulary outpatient cabotegravir for PrEP. So putting in the workflows for that. Insurance coverage has been challenging, but at BCHD, at the sexual health clinics, Liz Gilliams, Sean Adele, who had been running the PrEP program, they had, last I heard, they had given injectable PrEP to 7 people, which is actually quite a success given all of the logistics of this. So we're learning from their experience in terms of like the insurance, like it's really a lot of insurance difficulties. So more to come soon on being able to offer it in Bartlett.
Well, thanks. That's a super helpful update. And I think we also will have to watch this space carefully with the recent ruling suggesting that PrEP does not have to be covered in certain circumstances that were just released this week, and that may have implications for other preventive services, but in particular for PrEP access. So then the other thing I wanted to talk about was from the prevention space was an STI prevention intervention. So this was doxycycline post-exposure prophylaxis for prevention of STIs among men who have sex with men and transgender women who are living with HIV or on PrEP, so including both people with HIV and people on PrEP. And so what was the prior data that supported this approach? There was a study from the ANRS and the EPRGAY study, which looked at PrEP, where MSM who were on PrEP were randomized to take doxycycline at 200 milligrams times 1 within 24 hours of condomless sex versus no STI post-exposure prophylaxis. And they saw a reduction in syphilis and chlamydia, no difference in the rates of gonorrhea, and the median doses of doxycycline was 680 milligrams per month. So this would be about 4 doses a month of the doxy-PEP. So what did this study do? So this was an open label study with doxycycline taken as PEP within 72 hours of a condomless sexual contact and a maximum of 200 milligrams every 24 hours. You didn't keep taking it for more contacts. The inclusion criteria were male sex at birth, living with HIV or on PrEP, more than 1 or more STIs in the past 12 months. So they pre-selected for a population at risk, condomless sex with more than 1 male partner in the last 12 months. And then they did STI testing at quarterly from oral, pharyngeal, rectal, and urine, plus syphilis testing and a gonorrhea culture before treatment. This was done in San Francisco and Seattle STI clinics. So what they saw, so their primary endpoint was at least 1 incident STI during the follow-up quarter, and they had 80% power at their projected sample size to detect a sort of halving of the risk from 10% to 5%. But actually the DSMB halted the study early due to effectiveness in both the HIV and the pre-exposure prophylaxis arms. So who did they enroll? So it was 324 PrEP participants and 174 people living with HIV. The median age was 38, 67% were white. Median number of sex partners in the prior 3 months was 9, and 59% reported some substance use. Most of it was chemsex type of drugs, not a lot of opioids. And more than 90% were male, with the remainder either transgender women or identifying as gender diverse. And here are the results. So on the left, you see the PrEP cohort. On the right, you see the people living with HIV cohort. The left bar within each of those is the doxycycline PEP, and then versus standard of care, and then doxycycline PEP versus standard of care. Blue is gonorrhea, orange is chlamydia, green is syphilis, and 2 is more than 1. So they saw basically a 66% reduction in STI per quarter in people on PrEP, 62% in people living with HIV. So substantial reduction in STI incidence in this cohort. So symptomatic STIs, this was notable. There was a trend towards lower rates in the doxy arm. So in the doxy arm for PrEP versus people living with HIV was 15 and 17% had symptoms, whereas in the standard of care arm, 28 to 24% actually presented with symptoms. So suggesting that asymptomatic screening would be very important with this type of strategy. The anatomic distribution of where the STIs were diagnosed was mixed for gonorrhea and primarily rectal for chlamydia. They actually had very few syphilis cases, which sort of limits the predictive utility for syphilis in this case. So the major difference from the ANRS results are that they did see preventive efficacy for gonorrhea. And so in people with PrEP, this led to a 55% reduction, people living with HIV, 57% reduction in the risk of gonorrhea, larger reductions in risk of chlamydia, and syphilis was hanging near the significance in people living with HIV, which is only 174 people because they just had so few cases. So what are these results? A few other things. So 88% said it was an acceptable or highly acceptable treatment. There was only a 1.5% rate of discontinuation for intolerance or patient preference. The median number of sex acts was 7.3 per month, and 87% of them were covered by doxycycline. So suggesting that either patients were using it frequently, or that there was a high frequency of condomless sex in this cohort. And then this is the other thing to look at. So how many doses did they take per month? So less than 10 doses was a little more than half. 10 to 20 doses was 30%, so a full third, and 16% were taking more than 20 doses per month, which is getting close to near daily administration of 200 milligrams of doxycycline. And then what about resistance? So 30% of the gonorrhea test positive results actually had cultured data available, either because the cultures couldn't be grown or because resistance testing failed for some reason in the cases where they didn't have them. 20% of them at baseline, so before starting the study, 20% of the gonorrhea culture results had tetracycline resistance. This is compared to, I think, 56% in the French ANRS study, Ipergay, showed 56% resistance to tetracycline. So this was one of the reasons that the authors thought that perhaps they saw more efficacy in prevention of gonorrhea because there was higher rate of gonorrhea susceptibility to tetracycline as compared to the ANRS study site. When they looked at the breakthrough infections, there is a trend here. So here's the doxy-PEP in the middle, and then the standard of care on the right. The red bar is highly resistant. The orange is sort of intermediate, and the green is susceptible. And what you see in the doxy-PEP arm as compared to the standard of care arm is a larger proportion of this red bar. So there's two ways to think about that. Either that's emergent resistance on treatment, or that doxy doesn't work when you're not susceptible to doxy. The authors were sort of interpreting it as this was probably pre-existing resistance and the doxy didn't work because of the resistance, but I think longer and larger studies will be necessary to sort of sort out what the impact of this intervention could be. So overall, I mean, it was effective, really quite effective and well tolerated in this cohort. Unknown implications for antimicrobial resistance patterns in particular. And I did poll some of our local STI experts who I don't see Matthew here, and I don't see, or Khalil. And I'll say, I think Khalil is more hesitant about the broad application of this strategy because, I mean, to be honest, it looks like something we should potentially be offering to people who meet the criteria. With respect to the risk of antimicrobial resistance for gonorrhea specifically, but also the rest of the gut, potential impacts on the gut microbiome and or weight, and just which of the patients that we see for PrEP services would be most would it be most appropriate to recommend this for? These are patients who had at least one STI in the last 12 months. Should that be a criteria for adding doxy-PEP? Should it be number of sex partners? What are the reasons? How would we differentiate people who would be most likely to benefit? Matthew Hamill is more of a fan, and I think reflects partially different training sites and practice patterns, but I don't know. I mean, Joyce, have you ever recommended doxy-PEP for your PrEP patients?
Not yet. I guess I'm just concerned about the resistance piece and sort of contributing to resistance. And Khalil, I don't know, it's hard to do something that Khalil wouldn't do. So I feel like I'd like to just, it sounds like for the individual, it seems pretty clear that it's helpful, right? It's well tolerated and it reduced infections, but from like a sort of public health perspective, I guess that's and then the gut microbiome. But we do have experience with people being on longer term doxycycline, in other clinical situations. So I'm right now on the fence and not pushed enough to do it, but be interested to hear what other people think.
Yeah, so I was asked about it by a patient 2 years ago now, after there was some data presented, and he actually presented it to me as his roommate was told him there was a little red pill that could prevent syphilis. And I was like, wait, what is this? And this was sort of the earlier results from the Ipergay study. I have to say, like, several of my PrEP patients, their risk is overall quite low. And I think that's one of the features of the sort of PrEP to need ratio that's not captured by just that number, is like a lot of the people in my personal PrEP clinic who are engaged in PrEP services are quite fastidious about their risk reduction. And there are other people who are not coming to get PrEP and not coming to get regularly tested, who are probably at higher risk of both HIV acquisition and STIs. And in my PrEP practice, I think I've only had 3 STIs in the last 5 years. So it's certainly not all in the same individual. So for this particular population with a high rate of chemsex and at least 1 or more STIs in the last 12-month period, sort of pre-specifies a higher risk group than I personally am seeing. But I'd be interested if there's anybody else who does PrEP who's on the call who has other thoughts about how they will use this or not use this. Or we can remain silent. Oh, Ethel, yes.
Hey, Eileen, I just wanted to just raise a curiosity about the fact that doxycycline hyperconcentrates in urine and has been used for UTI treatment for ESBL organisms to achieve an MIC or a level 4 times the MIC, and has been successful because of that quirk of the drug, which is urinary hyperconcentration. And if we're treating urinary gonorrhea, whether that can be leveraged and whether that should make us have warmer feet or slightly less cold feet about this resistance concern, especially if it is a baseline resistance concern and if it is in that intermediate MIC range. So that's one thing. And then just the other thing, just to flag for our fellows, that whenever you have a patient who you want to give doxy to, who is telling you that they have GI intolerance, you should make sure that you try doxycycline monohydrate, because it is so much better tolerated. And usually I've had no trouble getting it through insurance. So really that's what I go to first, rather than doxycycline hyclate, in terms of being able to support people's adherence to this. I guess I am more on the Matthew side of being open to using it as PEP.
So thanks for those comments. That's super helpful to think about, and a really important thing with the ESBL questions. I see the questions in the chat about less effective in people living with HIV. So unknown, these weren't necessarily, we didn't get data about what the treatment status of those individuals were, or whether the syphilis data specifically was the one where it was not significant. And in syphilis, it was simply because they actually had too few cases to really reach statistical significance. And they had also enrolled many more PrEP users in the study than they had enrolled people with HIV, although their targets were much higher when the DSMB stopped the study. So they were only at about 174 people living with HIV versus the 300 some with PrEP. And I think their targets were in the 500s for both. It was just that the study was stopped because of efficacy. And in acceptability, how many patients were non-white? This is a really good question. This was done in San Francisco and Seattle. So one would predict that the majority of patients were white, with the remainder being Asian in background. And, you know, the other off-target side effects of doxycycline with sun sensitivity or esophageal irritation, you know, certainly the sun sensitivity can go across, but probably a little bit more likely in patients with the type 4 skin or whatever it is that I am that gets sunburned all the time. And then I see also Tom's comment about the cost being an issue and the protest at IAS over the access to cabotegravir. And I think that's a really good point, in particular in the regions of the world where we have like really clearly documented like extremely high rates of infection in young women in sub-Saharan Africa and poor adherence to TDF-FTC. Like, we should be getting those women cabotegravir. And then, so Chris, that's very interesting. A patient who has recurrent syphilis infections and has been on doxycycline and with good prevention of that. And the gonorrhea, again, chlamydia was the biggest reduction, although gonorrhea was a more frequent infection in this population in this study. So interesting, I think more to follow. And I think, you know, there's some of the same hesitancy that we had about using Truvada as PrEP at the beginning, because of like, this was also the basis of most of our treatment. And those have not panned out to be a significant resistance issue. With the doxy, a little bit more complicated because as I think Yuka could tell us, there's, you know, fewer and fewer options for some of these sexually transmitted infections. And Ethel makes a very excellent point about the use of doxycycline for certain ESBLs. So outside the sort of scope of what we're actually trying to prevent. So another study that was highlighted at the meeting was the Alliance study. So this was looking at bictegravir FTAF versus dolutegravir FTDF in patients with HIV/HBV co-infection. So the rationale is the high burden of chronic hepatitis B, including 8% of people with HIV and up to 25% in endemic regions, clinical consequences for HBV outcomes, increased rate of cirrhosis, higher HBV DNA levels, and guidelines currently suggest either TDF or TAF are both fine, but it's really unknown if there's a preferred nucleotide in the setting of HIV/HBV co-infection. And I'll just note, to my read of the studies that compare TDF-TAF in HBV mono-infection, there's really no difference in the efficacy. So this study was conducted in Asia with the majority of patients enrolled in Thailand, with the goal to evaluate effective treatment intervention for both viruses. So that was randomized 1-to-1 to either BIC/FTAF or dolutegravir plus FTDF. And not shown here on the slide, they were actually given placebos for the regimen they didn't receive. So everybody took 3 pills a day, which I actually missed in the first time I was thinking about this, and then later thought some of the conclusions might be related to 2 pills versus 1, but it's actually not true because they got 3, each arm got 3 pills, either bictegravir plus 2 placebos or dolutegravir FTDF plus a placebo. So it's double-blind HIV/HBV co-infection, and they were treatment naive for both. HIV RNA was greater than 500,000 and HBV DNA greater than 2,000 IU per mil. Genotypic sensitivity to FTC and tenofovir in their HIV, and a GFR above 50. So their co-primary endpoints were both HIV and HBV outcomes. And this is the study participant characteristics. So predominantly Asian, 89%, very low representation of women, 93% versus 98% male. Median age was in the 30s, median BMI was low, normal, but low if you were in the US. There was a substantial proportion of people with CD4 counts less than 200, so 38% and 43% in the two arms. And HBV E antigen positivity was high, so 76 and 80% in the two groups. About 50% had elevated ALT in the bictegravir group and 39% in the dolutegravir group. So here's the week 48 outcomes for HIV RNA suppression. And you see excellent suppression in both the dolutegravir, the bictegravir arm, which is the green one, and the dolutegravir arm, which is the gray one. And the mean change in CD4 count was statistically the same between the two, about 200 cells in the bictegravir arm and 175 in the dolutegravir arm. So where it gets interesting is in the HBV outcomes. So HBV DNA suppression, less than 29 IU per mil, was statistically better in the bictegravir F-TAF arm as compared to the dolutegravir F-TDF arm, with a difference of 16%, 63% suppression in the TAF-containing arm and 43% suppression in the TDF-containing arm. So then they looked at some other markers of HBV virus treatment response. So surface antigen loss was slightly higher in the bictegravir group. E antigen loss was slightly higher in the bictegravir group, although not significant across all the time points. Seroconversion was numerically more common for surface antigen in the bictegravir group and was statistically and numerically more frequent in the E antigen seroconversion for bictegravir. So to summarize, what they saw was superior TAF containing regimen. The TAF containing regimen was superior to the TDF containing regimen for HBV viral suppression, higher rates of E antigen seroconversion, 23% versus 11% at week 48, and numerically higher loss of other HBV markers, and also included, but I didn't show it previously, ALT normalization. So I'd already sort of, pre-asked Chloe and Dave Thomas what they thought about this, because I think the question that arises from this is whether international guidelines should specifically favor TAF over TDF for hepatitis B HIV co-infection. To be honest, it's not a huge issue, I don't think, in the US, where most people are on TAF anyway. But in Europe and other parts of the world where a lot of people are still on TDF, this would actually have implications for practice. Chloe, I think you're on, and I may just rudely call you out to see if you had any comments on this. I know that when we had chatted briefly, some of the other details weren't in what I had been able to tell you, but are you?
Yeah,
there?
so like you said, Eileen, there in the mono-infected individuals, there hasn't really been a demonstrable advantage of TAF over TDF. It's a lot of these details of this study still are not known, so we'll have to see what comes out. I kind of feel like this is a special population of people, especially because if you look at their surface antigen loss and seroconversion rates, those are extremely high. I mean, 12.6% surface antigen loss, that's really high. It's been seen in Thailand in another study. So it's, within what they see, but I think it still needs to be understood more about why that is so high. And the E antigen seroconversion rate also at 48 weeks is quite high. So I think that this might be a special population of people, and I don't think these are enough data for me to say that TAF is definitely better than TDF for hepatitis B.
Great. And I think, I don't think they're trying to make the argument that it's better broadly. It's just in this, if there was something special about HIV, although I don't really know what that would be specifically for hepatitis B, except for maybe promoting higher viral loads to come down from. But thank you for that. The other thing that was presented at this meeting was the HIV treatment, the bictegravir F-TAF data we were all waiting for. I don't actually think any of us were waiting for it, but it is actually reassuring to get it. So this is the 5-year outcomes of Biktarvy. So the thing that everybody uses all the time, we are just now getting our 5-year data on it. This is pooled data from 2 studies for registrational trials for Biktarvy. So study 1489, which was versus dolutegravir, abacavir 3TC, with 629 patients, and study 1490, which is versus dolutegravir plus FTAF with 640. And what they look at here is just how is Biktarvy doing over time. And this is just a point that came up actually at the meeting. Someone asked a question about this. So the open circles are when you treat missing data points as treatment failure. And this is about where at 5-year follow-up, most treatment trials will end up with like 67% response because I've just lost a follow-up. But if you treat missing people as just no longer being part of your denominator, then you have 99% suppression in the Biktarvy arm, which again is, both of these lines are for bictegravir. It's just considering missing data points as either failure or excluded. But overall, there was no treatment emergent resistance in any cases that were documented, and high sustained viral suppression. So here giving us a substantial number of people showing us that Biktarvy works. This is, which would have been really shocking if we had found out that it didn't, but good to actually have the data to confirm that. This is the weight gain data for Biktarvy. We've talked about this a couple of times before on other updates. And, one of the things is that sort of anytime someone changes a regimen or starts a regimen, there is weight gain. And this is the weight gain over different time periods, first 2015 to 2017, then 2017 to 18, and each year since then. And the +3 kilograms is in the per year is in the first period after starting treatment, which may be some return to health, suppression of viral replication, and the reduced metabolic demands associated with that. And then after that, pretty stable weight gain over time until we get into the sort of pandemic bloom, which I think we're still sorting out what exactly that means for weight gain in different populations. But this is not apparently that different than the amount of weight gain that the average person gains over years, which is somewhat terrifying, but probably true. And we see most of that weight gain in the initial period after starting treatment. So moving from that to weight gain data in general, this is a slide that I took from Paul Sachs that looks at the Tango and Salsa studies. So these are looking at weight change after you change to dolutegravir 3TC. So you go from, in Tango, you went from a TDF containing regimen, and in Salsa, you went from a TAF containing regimen, and in Salsa, you went from anything to a dolutegravir 3TC regimen. So if you switched off of a regimen containing TAF, if we look at the dark blue is the people who went on Dovato, dolutegravir 3TC, and the light blue is those who stayed on their current active regimen, the weight gain is totally the same. So you don't have to worry about incurring weight gain by switching to dolutegravir 3TC, but you also wouldn't expect weight loss. If you were on a TDF containing regimen, so tenofovir disproxil, the weight gain is more substantial than if you were on a TAF containing regimen, and the difference from your continuing your active regimen is the biggest. And so this is consistent with the message that has been emerging, which is that tenofovir disproxil appears to be weight suppressive, as opposed to the dramatic effect being from other agents being weight gaining. In the abacavir, switching off of abacavir, we see much more overlap with your continuing your own regimen, although the weight gain is a little bit higher than it was switching from TAF to dolutegravir. So this is trying to get at that question of, is it the integrase or is it the nuke? Meaning like, is it TAF that's driving weight gain, or is it the dolutegravir that's driving weight gain in all of these different studies? And what I think this suggests is that the time that you really need to watch this is if you're taking someone who, for whatever reason, is still on a TDF containing regimen, which for most of us would be if you're on the doravirine FTC TDF combination pill, or if you have some other reason for an intolerance or inability to take TAF. So still not totally clear, but it does seem like TDF is a little bit weight suppressive as compared to other regimens. And this is the week 192 results from the weight change in the advanced study. And I'll just mention briefly here that the Tango study was 90% male. So that was the one where you switched from a known TAF containing regimen to dolutegravir 3-TC, whereas the SALSA study was only 66% male. And the reason why this is relevant is because the advanced study, which was conducted in South Africa, comparing 3 different treatment initiation regimens, TAF, FTC, dolutegravir, TDF, FTC, dolutegravir, or TDF, FTC, efavirenz, the weight gain was substantial, but most marked in women. And so this data here now at week 192, it doesn't appear to have plateaued in the way that I think people were hoping. I think sort of the top of the curve here around week 96, people were hopeful it would sort of level out, but it does appear to have gone on to continue, with the weight gain over 192 weeks in the females on TAF, FTC, dolutegravir being, as high as 10 kilos, so upwards of 22 pounds, which is really substantial. This data actually remains one of the reasons why there was a couple of different treatment trials that looked at comparisons between dolutegravir and efavirenz, and some in the audience were suggesting maybe we shouldn't be doing those comparisons anymore. But there was a very cogent argument made from a female investigator in sub-Saharan Africa who said, there are some women for whom 22 pounds of weight gain is a substantial problem, and they want to be able to be on an alternate regimen. So I see Yuka saying in the chat, how many got diabetes? So it was not included in this particular abstract, but there are now data demonstrating increased risk of metabolic syndrome in people with weight gain associated with these regimens. So it's not benign. There is an increase in the risk of outcomes. So then I'm running out of time, but just a few quick posters actually. So this was looking at how good is TDF versus TAF? A lot of our patients are on it, but is it really more protective against declining in GFR? So the goals of this were to evaluate the impact of TDF to TAF while maintaining the remainder of the regimen on the GFR cohort characteristics. More than 90% male, mean age was 48, 15% African-American, and the data were collected between 2016 and 2019. But I'll just summarize here in the red numbers are the ones that are most important, but basically the difference in your GFR, which is the red number here, is like how much better you're doing on TAF. And so you're like 2.8 GFR units better on TAF overall, but the majority of that benefit is for people whose baseline GFR is less than 60, for whom they are 7.5 points higher on GFR as compared to those on TDF. It's really kind of neutral if your GFR is more than 90, and between 90 and 60, it's about 5. So still some benefit, but the biggest benefit really being concentrated in those with the lowest baseline GFR. Not shocking, but useful to know. I thought this abstract was also quite interesting. So this was a pathogenesis, like trying to figure out what the one way to treat cumulative viremia. So sort of getting like a pack years of smoking history for HIV viremia. When you have someone who's suppressed now and has been suppressed for 3 years, but they had 20 years of intermittent viremia, how do you calculate that impact on their overall health? So here they looked at, this is from the WISE, they were looking at relationships between cumulative HIV viremia and multimorbidity. The morbidities they looked at were hypertension, dyslipidemia, diabetes, cardiovascular disease, and kidney disease. And they only included individuals who did not have any of those at baseline. They adjusted for age, race, ethnicity, BMI, smoking, alcohol and cocaine use, CD4 count and nadir, and enrollment site across the country, and included 806 women with a median age of 39, 56% of whom were Black, 62% had ever smoked, and a median CD4 of 534. And so what they saw here is that your viremia copy years was associated with an increased hazard ratio for multimorbidity, meaning at least 2 of those diagnoses. And so I think that is, maybe will be helpful as we try to think about, how to talk about to our patients about why viral suppression is important, but also how to risk stratify them for complications later in life. And then finally, I did want to just mention this. This was presented as an abstract at the meeting, but also was recently published in CID. This is a demonstration project for long-acting injectable antiretroviral therapy for people with detectable viremia in an urban HIV clinic. So this was in their safety net Ward 86 clinic with high rates of substance use, psychiatric illness, and unstable housing. And they had good follow-up reported on 35 patients. They had a lot of on-site and remote services to support adherence, but they had good viral suppression using injection therapy in this population for whom it is not currently recommended, but for whom many of us would like to use it. So this is probably the first piece of data that hopefully more will be added to as we can add this strategy. And then the last slide I have for today is the final update on the, hopefully final, on the Sempeno study. So this was the study that in 2018 led to labeling of dolutegravir as being potentially a risk for, at the time of conception, for developing of neural tube defects. This was a study conducted in Botswana where there is no folate supplementation, but the initial rate of neural tube defects was 0.94. Which was greatly in excess of what was seen for other ART regimens and also for women without HIV infection. And over time, they expanded that study greatly to multiple different sites to sort of assess whether this was a true signal. And the point estimate has declined over time, with the most recent update that was just given at AIDS 2022, putting it at 0.11, which is identical to other antiretroviral therapy regimens and consistent with the background rate. And this is tremendously reassuring and sort of supports the recent labeling and recommendations in the DHHS guidelines for dolutegravir to be first line for use in pregnancy and periconception. So I had promised myself I would talk more slowly, but sorry for the rapid run through at the end. I know we're already over time, so I want to be respectful of that, but please feel free to email me if there are questions or things you think we should discuss more at a future meeting, and or like other topics that deserve a deeper dive. So thanks everyone for coming, and please do, if there's something we should talk about more, just send me an email and we'll find some time to talk about it in one of the upcoming conferences.
Eileen, are you going to post these? Because Kristen Kilcrease just wrote up the Cabenuva experience at our place, and she should look at that abstract. So I'm just trying to figure out where to refer her, to you, or are you going to post these slides?
Yep. So this was recorded and it'll go on the CFAR channel, but also the slides can be posted in Teams.
That's awesome. Thank you so much.
Thanks, everybody. Have a great weekend.